Hello, and welcome to all of you on behalf of the World Organization of Family Doctors, WONCA. This is the 5th webinar in our series on human factors and primary care. My name is Maud Nauta, lead of the Human Factors Core Group, the organizers of this series. Your main host for today will be Professor Richard Roberts. He will introduce today's excellent speaker, Dr. Şeyma Handan Akyön, for her presentation, Strengthening Doctor-Patient Relationship with Artificial Intelligence. Before we make a start with Şeyma's presentation, just a brief recap for those of you newly joining this series, what human factor science is about and what the Human Factors Core Group does. Human factor science is sometimes also known as the science of work. It's a fundamental pillar of the WHO Global Patient Safety Action Plan 2021-2030, and the Human Factors Core Group was established around 2 years ago. Human factors is a scientific discipline concerned with an understanding of interactions among humans and other elements of health systems. For today, that other element in the health system is artificial intelligence. The science is about designing systems in such a way that human well-being, yours, that of your patient, and overall systems performance are optimal. Today's webinars will take you through a changing environment we work in with increasing automation and AI tools, for some already available now and for others around the corner in the future. Times change and we change with the time. That brings me to the Human Factors Core Group vision. For family medicine, our vision is that by applying human factor science principles in strategic and day-to-day activities at individual and organizational levels, our primary care patients will have the highest attainable health and well-being, with care that is both patient-centered and free from avoidable harm. And as WONCA is a global organization, our Human Factors Core Group's mission is to lead within the organization on human factors integration in family medicine worldwide, supporting family medicine teams to develop their own human factors language, applications, research and education, adapted for their local circumstances. There are a few practical points for today. If you need to contact us afterwards, you can reach us via the email that we will list in the chat. The chat is active for all of you. And the chat is also there for you for your questions to the speaker or raise general discussion points. We will assemble your questions from the chat at the end for in the Q&A, led by Professor Richard Roberts. He will now introduce our speaker. Rich, over to you.
Thank you, Maud, and hello, everyone. I'm very excited to introduce to you someone that we've heard speak just recently at the WONCA World Conference in Lisbon, and she did a fantastic job. She'll be speaking on a similar topic, though adding some additional elements to it. And that is Dr. Şeyma Handan Akyön, who's a young family doctor and a researcher from Turkey. She leads a home health care group for housebound patients, and in her after clinic hours, few as they may be, she continues her research. She also co-leads the European Young Family Doctor Movement Digital Health and Artificial Intelligence Special Interest Group, is a member of the WONCA Human Factors Core Group, and is the latest fellow of the European Group on Primary Care Research Network Fellowship Program. She's published several articles and presented conferences and lectures and workshops on how artificial intelligence can serve to help physicians in their practice, and she's developed AI-based tools looking at things like drug-drug interactions and virtual patients for medical education as a part of an interdisciplinary academic project with her husband, who's an AI software engineer. And with that, I would like to introduce to you Dr. Şeyma. Please proceed.
Hello, dear Rich. Thank you for this amazing introduction. Thank you so much. I'm honored to be here. And first of all, I want to say a heartfelt thank you to Richard Roberts for supporting me on this journey, and all the members of the Human Factors Core Group, dear Maud, John, Raina, and their encouragement and invitation mean a lot to me. And I'm already learning so much from this field, human factor science, and this precious team. Today, my talk is titled Strengthening Doctor-Patient Relationship with Artificial Intelligence, AI. For me, what makes this webinar special is that we are trying to look at AI through a human factor science lens, not just as technology, but as something that changes how we work, how we think, and how we relate to our patients. Rich has already introduced me, but I recently asked the ChatGPT who I am based on our conversations, and it described me as a compassionate family doctor for human-centered AI. I know ChatGPT likes to make the user happy, but that is exactly what I hope to be. In the Hippocratic Oath, we are reminded that warmth, sympathy, and understanding may outweigh the surgeon's knife or the chemist's drug. As family doctors, this relationship with our patients, filled with empathy, is the backbone of our practice. So today, I would like to explore how artificial intelligence, AI, can help us protect and even strengthen that backbone. We will start with the basics of AI and what AI actually means, then look at the doctor-patient AI relationship from human factors lens, and discuss the main risks and challenges and strategies to overcome these, and finish with very practical tips on how to use AI safely, which I hope it will be beneficial for all. Before I begin, I would like to make a brief disclosure. I have no financial or personal relationship with any company or organization that could have influenced this presentation. So let me take you on a very quick tour of artificial intelligence. We start in 1950 with a question, can machines think? And soon moved on to powerful chess programs that could even beat world chess champions. In the 1970s, we built rule-based systems and full of if-then rules. For example, if fever plus cough, think pneumonia. They were useful but rigid. With the rise of big data in 1980s, millions of digital records and images, we finally had enough fuel for multi-layer neural networks to learn powerful patterns. And that's how modern deep learning was born. And this gave us machine eye, deep learning for images. This is a technology behind all those films where machines hunt humans, like the Terminator and many other films. But the same pattern recognition that Hollywood uses to scare us is now helping us in medicine. This machine eye enabled computers to see medical images and detect tiny lung nodules or early breast cancers that our own eyes might miss. Probably most of you know the Her movie. In that movie, AI says, I'm here. Since 2018, we've entered a new chapter, like in Her movie. Large language models, systems trained on huge amounts of text so they can understand our questions and generate human-like answers. And today, our software doesn't just see. It can also talk back to us. And the real question is not whether AI is good or bad, but how do we choose to use this new capacity in medicine? And to answer that, we first need a simple shared idea of what AI actually is. Very simply, AI is a software inspired by the brain, our human brains. It learns patterns from data and then uses those patterns to make predictions or generate text. It is like a system that quietly watches our data and imitates what it sees. But in healthcare, you will also hear the term augmented intelligence instead of artificial intelligence. The idea is that these systems are meant to augment, to extend and support human clinical judgment, not to replace it. Personally, I'm very happy to see this shift in language, and augmented intelligence is the term I prefer to use in the future. AI has transformed almost every sector, including healthcare. Based on latest reports, in Europe countries, most of the countries now have a cross-sector AI strategy in place or in development. Many already use AI for triage, chatbots, and administrative automation. Moreover, FDA approvals for AI medical devices have risen almost 40-fold in 8 years. It is obvious that we can't stop the healthcare AI adaptation wave, but we can learn to surf it. And it's not just at system level. When we look at 2024 data, the American Medical Association surveys show physicians using AI jumped from 38% to 66% in 1 year. It is a bit higher in young family doctors. In our latest published study in Annals of Family Medicine, 74% of young family doctors use an AI tool at least once. And these data are belong to 2024. We don't know yet the 2025 data. So we aren't watching the wave from the beach anymore. We are already in the water. A few weeks ago, Elon Musk, who is the guy who runs Tesla and SpaceX, said something like AI will replace doctors. So I'd like to start by asking you, do you agree with him? To answer that, let's remember this isn't his first big prediction. About 8 years ago, he said we would have fully self-driving cars within a year. Today, Tesla and other systems are really impressive, but they still require human control. So these AI will replace doctors next year statements are very attractive for investors and headlines, but real life is more complex. You may already have seen the headline, AI is 4 times better than doctors at diagnosing disease. But what does that really mean? AI has something we call a super memory. It can read thousands of papers instantly. When it faces a new case, it can immediately match it to the right knowledge. When it comes to the basic logic, even the best AI today performs poorly. I want to share a recent benchmark, ARC-AGI-2 benchmark, which is designed to see how well an AI can learn new skills for which it has not been specifically trained. That showed something striking. While the average high school student can solve simple reasoning tasks with 100% success, the newest AI models managed only 30%, which is the Gemini 3 Pro. Last month it was released. So AI may outperform us in pattern recognition, but it fails at simple logic and context, especially in real-world complex cases. The conclusion is clear. AI will not replace doctors, but doctors who use AI wisely may replace those who do not. Let's see the reasons. I want to zoom out and show why we even need help from AI. PubMed adds over 4,000 new articles daily, and medical knowledge now doubles in roughly 2 months. That mentioned Richard in his keynote speech in Wonka World. That means that what I know today can become incomplete in just a few weeks. Even if I did nothing but read, I couldn't keep up. So as family doctors, we are struggling with evidence overload, still trying to hold the line for our patients. This is exactly where well-designed AI tools can help, not as artificial intelligence, but as augmented intelligence. These tools don't replace our human judgment. They could help us access, prioritize, and synthesize the evidence we need. Let me paint a clearer picture. In the past, we supported our decisions with whatever guidelines we could remember and long, time-consuming literature researches. Now imagine we have a searchable supermemory in our pockets. Today, AI tools can already summarize guidelines, scan PubMed with a specific clinical question rather than writing only keywords. This is especially powerful in rare diseases and complex cases, where our individual experience is limited, but the global data set is huge. Think about how Tesla trains its autopilot. It doesn't learn from one driver, but from millions of kilometers and countless edge cases, almost like combining the experience of every taxi and bus driver in the world. A single driver might panic the first time a car comes towards them in the wrong lane or a dog jumped to road, as you see in the training dataset of Tesla. But the system has seen similar scenarios thousands of times. Their safety reports show that when autopilot is used as intended, accidents and fatalities per mile are lower than with human-only driving. So bottom line is, medical AI could handle to use that global knowledge to make the safest and most appropriate decision together. So, what do we actually mean by human factors science, and why should family doctors care? As Maud mentioned in the beginning very clearly, human factors or ergonomics is basically the science of how humans interact with systems. The aim is to design our tools, environments, and workflows in a way that optimizes both well-being and performance, not just productivity on paper. WHO recognizes human factors as a core element of patient safety. So, top-down policies like more guidelines and accreditation rules are not enough. We also need bottom-up redesign based on what clinicians really do in a busy practice. A classic human factors diagram shows the interaction between person, tasks, technology, and organization. And as family doctors, our relationship with our patients matters deeply because our competencies all depend on strong human connections. That's why, for the rest of this talk, we'll zoom in on the person-technology interface, how AI and digital tools can be designed to strengthen rather than weaken the doctor-patient relationship. If we zoom out a bit, the doctor-patient relationship has changed a lot over time. We moved from a paternalistic model, which is doctor knows best, patient just follows, to shared decision-making approach, where the patient's story, context, and preferences are also important. Firstly, digital health technologies arrived, which are electronic health records, clinical decision support tools, or telehealth technologies. Then artificial intelligence entered our consultation room as a third player. Yet the core ingredients of relationship have not changed. We will still need trust, empathy, continuity, and time. So, when we ask, did electronic health records, EHRs, save our relationship or make it harder? And the answer is a bit both. Digital health technologies brought benefits, continuity, safer prescribing, better quality, patient empowerment, but also burdens, more screens, alerts, inbox messages. And one of them is alert fatigue, steals our attention and cause less time with patients. This is exactly where AI can help, not by adding more screens, but by filtering noise and giving us back time and presence. So when we look at who else in the room with us now, here we are talking about ambient AI scribe tools. These tools are silently record the conversation between us and our patients and create notes automatically. Studies show documentation time can drop by up to 50%. Burnout of physicians reduces, and patient communication improves with these new technologies. And the market is exploding. Roughly 60 ambient AI scribe tool solutions are all around the world. And surveys suggest around half of primary care clinicians have already tried some kind of AI tool. But we should be careful about privacy, informed consent, and strong human oversight, which means doctors revising the notes after consultation is quite important. Ambient AI scribe tools are really exciting. They really do reduce the time we spend writing notes, but that is only the visible part of our clinical workload. Under the surface, we still have repetitive, low-risky, time-consuming works such as inbox messages, summarizing notes and test results, admin work, billing, so on. If we want AI to reduce burnout truly, it needs to help with this hidden part of the iceberg as well, not only with documentation. And for this, as a good example, there is also AI that can help us make sense of the data flood. This latest example from Epic, which is major electronic health records company, that they showed us an implemented AI feature to the electronic health records that supports doctors and patients before, during, and after the visit. by secure chat, summarizing notes and test results, highlighting key data, drafting documentation, and automating follow-up and admin tasks. In their latest report, this AI feature implemented to electronic health record cut time spent in notes, in secure chat, and results review. And similar AI-based systems in recent papers reduced alert burden up to 90%. So this is AI not just for documentation, but for the whole administrative shadow. The promise is the same: less time hunting and typing, and more time thinking and talking to our patients. In summary, across whole consultation, where should AI stand and where should we stand? This diagram shows the full journey of visit. AI can support us at each step, but always in the background. During history taking, AI can capture the story so we can keep eye contact with our patients. In data synthesis, AI can summarizing the electronic health records, previous notes, and guidelines. In the decision phase, AI can suggest differential diagnosis and risk scores, but the clinician verifies, adapts, or rejects them. We are still the authority of clinical judgment. And when it comes to explaining the plan, for example, a newly diagnosed cancer, we lead the conversation with our empathy. The goal is simple: use AI to reduce error and time pressure so we can focus on what only humans can do: connect, listen, and heal. And as family doctors, we are not only clinicians, we are also patient advocates. That means we can't just plug in any AI tool and hope for the best. We have a responsibility to ask, can my patients, or can I safely, can we trust AI? When we talk about trust, one big problem is the black box. A black box model takes in data and gives an answer, but we don't really see how it got there. That makes it very hard for clinicians to know when to trust it and when to override it. In healthcare, we need to move from black box to a kind of glass box. And ethical guidelines explicitly calls for transparency, being open about how these systems work. And this is the concept of explainable AI. Explainable AI means the system doesn't just give a result, it also shows the main reasons. My husband, he is AI engineer and doing his PhD on AI, and his specific field is explainable AI. So I'm deep in this topic. There are many strategies in this field and working. And the second trust problem is what we politely call hallucination, which means confident but wrong answers by artificial intelligence. Sometimes they even invent trials or journals that don't exist. That's why many groups are now working on what I like to call evidence-based AI, technically known as retrieval augmented generation, or in short, RAG. Instead of answering from its fuzzy memory, the model has to retrieve information from a specifically selected library or sources that given by you, and then generate an answer based on that evidence. Ideally, with references we can click. Systemic reviews shows that these retrieval augmented generation systems can reduce hallucinations. But even evidence-based AI is not a silver bullet. It can still miss key papers, evidence can be low quality, and the model can still misinterpret what it reads. So the rule remains the same. AI proposes, doctor decides. Our job is to keep clinical judgment awake. And the last trust issue is overtrust, which is our tendency to believe the computer. And studies show that clinicians sometimes follow incorrect AI advice, even when their first instinct was actually right. So, automation can be safe and helpful in low-risk repetitive tasks. These reduce admin burden without touching the core of our clinical judgment. But we must keep human oversight, and especially critical and clinical thinking, which means the system should always remain under human control. Additionally, if we let AI silently make decisions, we are at the risk of descaling, losing important skills we don't practice anymore. But on the flip side, if AI handles routine tasks, we might free up time for higher level critical thinking. And there is one more thing about critical thinking. We can only think critically in areas where we understand the basics ourselves. I sometimes hear colleagues say, "This is great. Now I don't need to pay a statistician anymore. I'll just ask AI." But this is actually a false conclusion. If you don't know enough statistics to do the analysis yourself, or at least roughly follow what the statistician does, then you don't know enough to safely hand it over to AI. You won't be able to see when the model makes a wrong assumption or draws the wrong conclusion. So, AI can amplify or augment our skills, but it should not be a substitute for having any understanding at all. We still need a minimum level of domain knowledge to look at AI's answers with a critical eye. And there is another important issue that affects our relationship with our patients in this digital era. More and more patients arrive having already consulted a chatbot. They now come with AI-generated interpretations of their history, symptoms, laboratory results. And in one sense, this is real empowerment. People are more informed and engaged than ever. But there is a flip side. These tools often give dramatic, worst-case answers. A headache becomes probably a tumor. And I talked about hallucination. It's a big problem. Then we face this challenge. The patient believes ChatGPT, Dr. ChatGPT, but we know it's wrong, and proving it in a short appointment isn't easy. This creates confusion, mistrust, and digital infodemic. We can't just dismiss these tools. We need to understand how they work so we can guide patients through AI-generated health information. We should start with ourselves. So for this aim, I'd like to share some practical tips. If you want to large language models, LLMs, as allies, not enemies, we need some basic AI literacy. I use a simple 4-step checklist. First, disable training wherever possible. So our clinical chats or our chats with large language models aren't feeding someone else's models. Second, let the AI know you. And third one is practice good prompts. And fourth, always check resources, which means human oversight I mentioned. These are like practical tips for quality and for your own safety. Before we start the steps, the first safety issue is privacy. Most general large language models may log what we type, which is fine for holiday planning, but not for clinical cases. So we follow 3 simple rules. Use, whenever possible, approved tools or licensed tools with your hospital or your clinical settings. These tools could be on-prem technologies or health cloud platforms with no training on personal health information. These kind of environments are really safe when we compare with other general cloud systems like ChatGPT and Cloud or the Gemini. On-prem systems, I told the on-prem, these systems are fully controlled by your organization, your hospital or your clinic, and run on your own servers. This makes them the most secure option, but they require hardware. They are really costly and less scalable. If you don't have these technologies, be careful with sharing sensitive data on general cloud AI systems. First step is identifying the data by removing names, dates, locations, and anything that identifies a patient is crucial or person is crucial. And the second rule is set local rules. For example, we never paste full discharge letters or upload identifiable photos on the large language models. So let's continue with how to turn off data training with your personal data. Here's a practical example with ChatGPT. If you go to settings and the data controls, you can switch off use content to improve our models. That means your conversations are still stored for your own history, but they are not used to train future models. You can use this QR code and below on the slide to video screenshots for ChatGPT and other tools, Cloud, DeepSeek, and Gemini. And another important step is personalization. When we give a large language model stable instructions, for example, I am a family doctor in Turkey, follow national guidelines, answer in clear B1 or Turkish, B1 English or Turkish, we give the model more context about our world, about our context. In this way, the AI's responses become more relevant and grounded in our reality. On this slide, you can see example of personal instruction sequence for ChatGPT. The example instruction from my husband, and he gave permission to use his profile from one of his latest talks on AI. And you can also use the QR code to reach out for Gemini, Cloud, and DeepSeek companies. Even with a good tool and good settings, we still need evidence-based prompts. Instead of what should I do, prefer to ask, use these sources only and summarize with citations. For example, these 3 sources, please use these 3 sources. This kind of prompt TGM keeps the AI honest. I also like to add, tell me if the evidence is weak or conflicted. This really helps because if you don't explicitly invite uncertainty, the model may prefer to give a confident sounding answers, hallucination, rather than admit it doesn't know. And of course, we still verify everything. We click the links, open the PDFs, and check for fake or hallucinated citations. And one last point I want to add. Everything I've shown you so far works with the free version of ChatGPT. With the paid version of ChatGPT, you can build your own custom GPTs, specialized chatbots using your own guidelines. This is a great example, is Dr. Leafy, I think, if Leafy, created by Dr. Rita. I'm showing this because it's a perfect example of using AI to improve doctor-patient relationship in a positive way. Dr. Leafy is designed to help patients understand their conditions using clear, friendly language, even in the patient's own language, other than English or Portuguese, for example, Hindu or Bengali language. To create one, you just go to Explore and My GPTs and create and upload your guidelines and your prompts, specific prompts. In simple terms, this is the easiest way to apply retrieval augmented generation, RAG, I mentioned before, for evidence-based AI, using your own trusted documents, which dramatically reduces hallucinations and makes the answers much safer and more reliable for your patients. You need a paid account to build your own custom GPT, but you can use any custom GPT developed by other people. For example, you can use this QR code and reach out to these Dr. Leafy by Rita Abakis and use for free. And let me close with 3 messages. AI is becoming a third presence in the consultation room. But if we design it well, it can support the doctor-patient relationship. The risks are real, and so we need transparent, evidence-based use of AI. And its real value is saving our time and mental load so that we can invest more in empathy and communication and critical thinking. As Eric Topol says, the opportunity of AI is to restore the human touch with time-honored connection and trust. Thank you all for your patience and attention, and a special thanks to the Human Factors Core Group for inviting me. I hope your living with at least one idea you can use in your practice. You can scan the QR code for my contact details and special interest group, digital health and artificial intelligence, special interest group information. On this slide, there are few books I highly recommend if you'd like to explore the topic further, AI in healthcare. And I'm happy to take your questions now. And for the very advanced level technical ones, maybe my husband Fatih will kindly join us. Thank you so much.
Well, thank you, Dr. Şeyma. That was an excellent presentation. And I took away a couple of conclusions, I think, that you were sharing with us, that AI for a physician is not the end of our decision-making process, it's the beginning. And just
Yeah.
as with any beginning, you've got to understand how it works. You have to understand what evidence is it used to come to its recommended outcomes. But it's a long way from data, which AI does fabulously, to knowledge, which AI does somewhat well, to judgment, which does not do a very good job of. And I appreciated your highlighting those points. I see basically thus far only one questioner, and that was Dr. Rick Botello from the United States. And what Rick, I think, is asking is, as you deal with the very rapid acquisition or obtaining data and information through AI, you have humans that still process this kind of slowly. And how do we sort of meld the two together? In other words, how does a human keep up with the AI, or how does the AI slow down for the humans to come to
Yeah.
ultimately good judgments? And Rick calls this neo-learning, a new way of learning. What are your thoughts on that?
It's a perfect point. Yeah, exactly. It's kind of a productivity paradox. We have a lot of information, and the AI is already really so quick. And how to keep up with this technology is a great question. Maybe it's important to know how to use AI in which settings and which areas, and to support us. And as I mentioned in my presentation, in the knowledge base, AI could also help us to prioritize and select the appropriate or relevant evidence and to use it in our practice. Maybe it is an issue, and how to deal with these improvements. But also in that challenges, AI could help us, in my opinion. Yeah. Do you, if Fatih wants to add any other, as an AI engineer, maybe he can have another opinion if you would like to hear.
Yeah, I can add very simple few sentences to this topic, because it's the same case in the engineering field as well. With the AI tools, the number of, let's say, codes written each day increases hugely, and human engineers need to review these AI
Thank you. You've kind of frozen on us, Fatai. And what I'll do in the meanwhile is, if I can, is to go on to another question. And this
actually
had to do with.
And this is okay. Is it?
Go ahead, Fatai.
Is it okay? So can you hear me now at the moment, or?
Yes, now you're good.
Okay.
Thank you. Please continue. I'm sorry.
Okay, good. No problem. So what I was going to say is that with the raising usage of and the adaptation of AI, there will be more need for actually human engineers and human doctors to review and actually, let's say, analyze the output of these AIs. So yeah, it will just increase the demand for doctors and engineers and human workers actually.
Thank you very much.
Thank you.
There was another question that asked, for a simple country doctor like me, where do you start? Let's imagine that I'm in a very rural or remote area. The electronic records that I keep are on my mobile phone. I don't have access to a nice library full of books or librarians to help me with research. I'm very tempted to use AI to help collect the latest information, and even perhaps to help me with pattern analysis in my own practice. But for somebody like me, where would you start? What's the first thing you would do?
Perfect question. It will be the basic that increase our AI literacy, because as I mentioned that this wave is already in there and we need to understand the limits and challenges and these kind of tools. And if you don't have opportunity, for example, in my case, in my hospital, I don't have, as I mentioned, on-prem systems in my hospital, AI tools, AI systems licensed with my hospital. If you don't have these opportunities, it maybe not be appropriate to say a single winner as AI tool, but all the large language models are useful, in my opinion. I've tried all of them, Gemini and ChatGPT, to use their deep research features. It could be helpful, but as I said, please be awakened about the hallucination things. And one of I really like to use tool is Notebook LM from Google. If you don't hear that, Notebook LM, I highly suggest you, because you can use this AI tool. It's also a large language model and it's completely free. All the features are free. You can use this AI tool to give text articles or YouTube link, and you can it's like you can talk with this article or you can talk with this specific video, and you can ask questions and you are having answers. And it's really using the retrieval augmented generation evidence-based systems, and it's stick to what you give to your Notebook LM tool. And also one of the feature I really like to use, you can give your article to that tool, and for example, a newly released article, you can give it to that and you want to read it, but you don't have time. Mostly I do like this. I'm giving this article to that tool and transforming it to a podcast, and it's really real life podcast. It's like, please try and you will understand what I say. When you give that article or text or something, it can transform it to a podcast, and you can listen when you're driving to your work or you're coming back from your work to your home. I find it's really useful if you want to use it.
Very good. Thank you.
Okay.
Some of this reminds me of conversations I've had that go back over 50 years. Ray Kurzweil is a pretty famous inventor in the area of computers and electronic devices and such. And he was the guy that developed the Moog synthesizer, for example. And Ray's been talking about this idea of a singularity where the human mind becomes melded or enmeshed with an electronic mind. I think I see some elements of that with AI right now. And one of the worries, though, that results is, do you think this will cause us as physicians to, in some areas of our work, get dumber, become de-skilled? We don't do certain things that we used to do. I mean, for example, we know that when people actually physically write something down, they are more likely to remember it than if they, talk about it into a computer screen and have the computer record it. What are your thoughts about the potential risk for doctors losing some of those skills?
Mm-hmm. Yes, very great question, dear Rich. And I've seen it in some literature about de-skilling. Yes, it could lead de-skilling of us. In recently released article, there was statistics that the doctors, the gastroenterologists doing colonoscopy with the help of AI on diagnosing cancer, and after 3 months, when they close that AI support, the rate of detecting cancer from colonoscopy drops. So it's about also kind of maybe we rely on a lot, or it's kind of a de-skilling. If we don't use our muscles, it will lose as soon as in somewhere. So I think it is very important to decide which areas we should use AI, and which areas we really need to be as a whole person in that area. And you mentioned that in the critical thinking, in that part we should be really active. But for the repetitive or low risk things, it could be nice to use these kind of tools to have much more time for that exactly important critical thinking part. Maybe it's not important to have the skilling about repetitive tasks, writing notes or something. I'm not sure. It's also another thing that writing is also thinking. So we don't know the ambient AI's effects on maybe effectiveness of our decisions. We don't have this kind of, as I know, this kind of literature right now. But in the future, it could be really nice to do this kind of studies also, effect of using ambient AI to our decisions, maybe. Yeah.
Well, questions to answer. I certainly agree at this early stage in the development of AI. Um, One other area of concern I think that many of us have with AI is safety. We've heard some of the horror stories of teenagers apparently being prompted to commit suicide based on interactions with an AI software system. And I just read a very recently released report on the 8 major AI products that are out there, all of which failed miserably when it came to this issue of safety and safety controls on them. And so my question to you is, those concerns about safety are in many ways even greater than using AI to plan my holiday versus AI to actually help guide my therapy or involvement with patients. What are your thoughts about safety? And maybe Fatai can also help us a little bit with understanding from a technical standpoint what needs to happen to make sure that we can use AI tools with in terms of safety, use them with confidence.
Yeah, perfect question, dear Rich, and important concern. I think one of the biggest challenges right now is the gap between our ethical safety guidelines or frameworks and speed of AI developments. It's really a few weeks, it's increasing exponentially. So it's really difficult to keep up with these developments by the side of the guidelines and the ethics. And on safety, it could be really nice to have worldwide guidelines for safety issues or ethical guidelines. In my opinion, it could be really nice to have your ideas also, dear Rich. You also searched on it. I know you're preparing. It could be really nice to have your ideas on it. Maybe Fatih will add something.
Yeah.
Or
First of all, these AI companies need to work much better on the alignment of this AI, let's say, models with the human values, let's say, important human values. In the future, actually, there are lots of let's say, research going on towards aligning these AI's values with the human values. Because if humans if AIs lack this empathy, or let's say thinking, including these thoughts in while generating some outputs or making some decisions, they should consider lots of things as well. And also there is another side of the thing that I think maybe the parents that let their children have access to these tools also needs to be maybe needs to know more about what these AI tools are capable of, and maybe somehow we should increase the awareness towards being more cautious when letting children access to these tools.
Good answers. You know, one of the things that gives me hope is even in the world today, which in many ways seems to be, you know, more fragmented, more conflict than ever, or at least in our recent memory, there are things that have happened in the world of the internet that cause me to feel hope. For example, around user privacy, we now have choices that we didn't have a few years ago as to what information you want the browser that's collecting information on you to be able to send off to third parties. Much of that came from Europe, and they developed basic set of rules or guidelines about that, and it's been adopted, I think, more generally around the world. So I do see the potential for good things to happen, but like all human developments, it'll probably be slow at times and then fast at times as we go forward, and it'll never be quite as simple and coherent as we might like. But as I say, I do think there is a way forward, and experts like Fatai and Şeyma will help us, I think, get there. One other question that had come up that I wanted to ask is when we look at using AI, at first we're all kind of enthused, excited, well, at least some of us are, and kind of eager to try it. You know, what we know from studies of trust is that when you have a relationship with somebody, trust is often very high right at the beginning. But when it screws up or somebody says or does something that we don't like, trust drops dramatically, and then it takes much longer to restore the trust. And that's one concern I have with AI. AI is going to be, over time, like any new, you know, human development is going to trip and stumble and fall and cause harm that was unintended but happened nonetheless. How do you see that as helping or hurting the overall drift or movement toward AI, especially in healthcare? This
I
idea of
understand.
trust in what you're getting. To say it in a slightly different way, if the AI is so good, why are you asking me to kind of recheck its work every time I start to use AI for a clinical decision? You know, why do I have to go back to the evidence? How would you answer that?
Yeah, great question, dear Rich. Yeah, not in English, how can I say, but it's not good as good as we imagining right now. But I think there is a hope, and in this stage, we still need human oversight, but it could be in the future maybe some really high risk things that we can give the AI. But in this duration, we really need a lot of evaluation, but implementation based evaluations, because in our in the recent literature, mostly in narrow tasks, they did kind of maybe randomized clinical trials, but in simulation based cases or in narrow tasks. So we don't know the real world data right now. If we do these kind of things and we will be sure about it, in that time, maybe we can have some systems that we don't need human oversight. But in this stage, in my opinion, we need still human oversight. But I'm kind of optimistic, and I think that I'm not sure that we really need a future that we don't need any human oversight on any technologies. I'm not sure about it. It's in this stage also, it's really helpful, but it could be more helpful because as I know, there are a lot of, as I mentioned, explainable AI technologies, strategies are developing, and trust issues are developed. Some strategies for trustworthy, this kind of responsible AI things are working now. So in the future, it may be better, but in this stage, it's also really helpful, in my opinion.
You know, what your answer reminds me of is, and I'm not a huge Star Trek fan, but I have people that are friends that are huge Star Trek fans. And what they always tell me about the doctors in Star Trek, whether it was the original series or the Next Generation or whatever, is that in each instance, they had this incredible technology that would bring all this information to the doctor, Bones McCoy, Beverly Crusher, and then the third series it was Dr. Hologram. But ultimately, what really helped or didn't help the patient do well or do better was that clinical judgment, that sense of empathy. And in fact, even Dr. Hologram, who started off looking more like an emergency physician, but ended up looking more like a family doctor with a more holistic view of things. So I agree with you. I think there is cause to be hopeful. But you know, it's one of those issues that as we go along, we'll have examples of bad things, and we need to know how to rebuild or restore the trust. For me, what I think AI has helped me the most with is it takes me from 4,300 articles published each day to narrowing it down to a manageable number that are really most likely to be useful to me. And then I can go through those sources and say, oh, I agree with this, I don't agree with that. So it's a tool like any other tool. And you know, tools can harm us if we're not using them properly, or tools can help us quite a bit. So we're coming on to about 5 minutes before the hour, and I wanted to give any of the audience just a last moment if they have a burning question. There's some great chat discussions going on, examples from Australia and things like that. And so I think that you know, from my vantage point, Şeyma, this has been a great talk. I think you've really stimulated a lot of thinking among people out there. And so, any final comments you wanted to make in kind of summing up your session today?
For me, I'm really thankful to have this opportunity. I don't think that it's a magic tool, but we really can use this tool to help us. But it's our responsibility to discover which areas that we can use AI to make it more powerful than we make it, rather than make it's weaken. I'm sorry. Yes. And I think there is one more. Rick Patel who raised his hand.
Yeah, I'll be very
Yeah.
brief. 30 seconds. While you were talking, I did an AI search on the question. I put it in the chat there, looking at 9 AI outputs about how we can develop AI and our collective intelligence skills beyond the rigor of critical appraisal. It's an aspirational question. It's an initial exploration. It creates a foundation for further inquiry and discussion. So I hope this theme will continue to be discussed. Thank you very much for your presentation. I really appreciate attending.
Exactly. Thank you so much, Derek. Yes, it's really important. I will also search and focus on that area.
And so one final thing I'll share with the group and then hand it over to Maud to close out for us is Diarmuid Hayes from the Secretariat Office of Wonka reminds us that May 19th each year is World Family Doctor Day. And the theme of this upcoming Family Doctor Day is, and I want to make sure that I say it right, so I'm going back to, it's called Compassionate Care in a Digital World, which seems to me to build nicely off of what Dr. Şeyma has talked about today. So, Maud, if you could take us to the closure here. Thanks very much to Şeyma.
Yes. So as we're nearing the end, a big thank you, Şeyma, for your wonderful session with us. Also, a big thank you to our technical support from the Secretariat, Wonka Secretariat, Diarmuid Hayes. Our 6th webinar in our series on human factors and primary care will be around January, February of next year, 2026. To all of you in the audience, we hope you enjoyed today's webinar. We wish you a pleasant continuation of your day or evening, and thank you on behalf of the whole Human Factors Core Group. Goodbye.